Hello students, I myself Dr. K. Mohammed Adhil, Assistant Professor from Department of Periodontology from Minayamission Sankaracharya Dental College. Today, let us see about aggressive periodontitis. These are the contents that include introduction, historical background, classification, that is localized aggressive periodontitis and generalized aggressive periodontitis, and risk factor for aggressive periodontitis, its therapeutic modalities, and conclusion. Aggressive periodontitis comprises of group of rare, often severe, rapidly progressing form of periodontitis, often characterized by an early age of clinical manifestation and distinctive tendency for cases to aggregate in families. Basically, in periodontal disease, we have two classifications. First one is said to be a chronic periodontitis, and second one is said to be aggressive periodontitis. The chronic periodontitis is nothing but there will be gradual onset loss of periodontal structure, whereas in aggressive periodontitis, there will be a rapid destruction of bone and surrounding structure on a short duration of time. This is a two basic diagnoses where we can see in periodontal diseases, that is chronic periodontitis and aggressive periodontitis. Now let us see about historical background. In 1923, Gottlieb has found this disease was characterized by a loss of collagen fiber in periodontal ligament and the replacement by the loose connective tissue, so that he has termed that it as a diffuse atrophy of alveolar bone, whereas in later by 1928, the same Gottlieb has found out there is an inhibition of continuous cementum formation, so that he has termed this disease as a deep cementopathia. Then in 1938, Van and Macker has described there is an involvement in incisor first molar involvement, so that he termed the disease it as a periodontitis marginalis progressiva. In 1966, in the World Workshop of Periodontics, the term has been rechanged it as periodontosis. Later in 1969, Chatput and Butler, they have been described this term as a juvenile periodontitis because this disease will occur only in young adults, so that they have been termed it as a juvenile periodontitis. Later on, 1989 workshop, they have been classified it as a early onset periodontitis, and in 1999, the World Workshop in Periodontitis, they have termed, at last they have termed it as a aggressive periodontitis. But basically, depends upon the recent classification, that is 2017 classification, there is no term called as chronic or aggressive periodontitis. They have been classified the periodontal disease based on the grading and staging criteria. Aggressive periodontitis is defined by Baer, who has defined this aggressive periodontitis as disease of periodontium occurring in otherwise healthy adolescent, which is characterized by rapid loss of alveolar bone, more than one tooth of permanent dentition. In this, we can add other thing like there is the amount of local deposit does not commensurate with the amount of destruction. In this definition itself, we can see how the aggressive periodontitis occurs, because it occurs only in healthy adolescent and it is characterized by the rapid loss of alveolar bone around more than one tooth of permanent dentition. This definition was given by Baer, and the Baer has given 7 criteria to define the disease. This is the most important one. The first criteria is to be age of onset. In aggressive periodontitis, the age of onset is to be circumpubertal onset. The second one, there will be distinctive pattern of alveolar bone loss, that is, there will be an arc-shaped bone defect where we can identify in radiograph like OPG or VGs. Then third one is to be a rate of progression. There will be a rapid rate of progression. There will be amount loss of 75% of bone within short period of time, that is 2 to 3 years. Then the primary teeth are not affected, only the permanent dentition teeth are affected. Then the fifth one is to be the most important thing, because the amount of local etiological factor is not commensurate with the severity of periodontal destruction. Because in case of chronic periodontitis, the main culprit or main etiology is to be local factor, that is plaque and calculus, whereas in aggressive periodontitis, there will be minimum amount of plaque and calculus, that is said to be etiological factor. Then the sixth one is sex ratio. Obviously, the aggressive periodontitis, there will be female preponderance, and the female-male ratio is said to be 3:1. And the last one is said to be, it runs in a family, the disease has a familial pattern. This is the 7 criteria which is given by the Baer to define the disease. And aggressive periodontitis classified depends upon the involvement of the teeth. One is said to be a localized aggressive periodontitis, and second one is said to be generalized aggressive periodontitis. First, we will see about localized aggressive periodontitis. As the name, the word term localized is nothing but it involves only the 2 teeth or above less than 2 teeth. First, the localized aggressive periodontitis occurs only on the age of onset about puberty, and it involves only the localized involvement of first incisor and permanent molars. there will be an interproximal attachment loss in localized incisor and first molar in the permanent dentitions. There is a reason for site restriction because the localized aggressive periodontitis occurs only in incisors and first molars on permanent dentition, because there are 4 reasons behind that for this localized restriction. The first reason is said to be after initial colonization of the first permanent teeth to erupt, aggregative bacter actinomycetin comitant, which is said to be a causative agent for aggressive periodontitis, which evades the host defense by the different mechanism that inducing production of PM and chemotaxis, endotoxin, collagenase and leukotoxin and other factor, so that after this initial attack there will be adequate immune response that will be developed, there will be release of many opsonic antibodies to enhance the clearance and phagocytosis of invading bacteria, and there will be neutralized leukotoxic activity, so that after this, in this manner, there will be a colonization of other site will be prevented. In this case only there will be localized distribution, that is, it will be involve only the incisor and molar, other than that it will not involve other than teeth in case of localized aggressive periodontitis. Then comes the second reason, the antagonist to AA comitants may colonize the periodontal tissue and inhibit AA comitants from further colonization of periodontal site in the mouth. And the third reason, AA comitants lost its leukotoxin producing ability for unknown reason, so that the progression of the disease may become arrested or impaired and colonization of new periodontal site may be averted. The fourth one, due to the defect in cementum formation, there will be responsible for the localization of the lesion. This is the 4 reasons behind that there is a localized restriction of periodontal structure. Then we will see about the clinical feature. In the clinical, there will be a lack of inflammation despite the presence of deep periodontal pocket, advanced bone loss. The amount of plaque on the affected teeth is minimal, which seems inconsistent with the amount of periodontal destruction present, as we already mentioned. Then the primary feature is non-contributive medical history, rapid attachment loss and bone destruction, familial aggregation of the cases, and secondary feature, there will be amount of deposit inconsistent with the severity of periodontal tissue destruction, and second, there will be elevated proportion of aggregative bacter actinomycetin comitants, which is a possible causative agent for aggressive periodontitis, and there will be abnormalities in phagocytosis, there will be a hyperresponsive macrophages phenotype, including elevated production of prostaglandins and interleukin in response to bacterial endotoxins. In clinical, we can see there will be distolabile migration of maxillary incisor with concomitant diastema formation, and there will be increasing mobility of the maxillary mandibular incisor and molar, and sensitivity of the denuded root surface to thermal and tactile stimuli. There will be deep, dull, radiating pain during mastication, and in case there will be periodontal abscess may form at this stage, and regional lymph node enlargement can be occur. And there is something called a Bernard phenomenon. Initially, it was thought that localized aggressive periodontitis gradually become generalized aggressive periodontitis over time, but in some cases, localized aggressive periodontitis does not show any increased bone destruction. They are known to arrest spontaneously, which leads to the cessation of the disease, so that they have termed it as a Bernard phenomenon. And this is a radiographic finding. This is the most important thing in aggressive periodontitis, whereas in chronic periodontitis, there will be horizontal, most probably there will be horizontal bone loss, where in aggressive periodontitis, we can see it has a vertical loss of alveolar bone around the first molar incisor, beginning around the puberty in otherwise healthy teenagers. There will be arc-shaped loss of alveolar bone, which will be extending from distal surface of the second premolar to the mesial surface of the second molar, and there will be the image will be mirror pattern. The alveolar bone usually similar to on right and left side of the mouth, and it will be bilaterally symmetrical, which you can be appreciated in the below radiograph. This is a clinical picture where we can see there is a arc-shaped defect in the first quadrant and second quadrant, which is to be bilaterally symmetrical because the bone loss extending from the mesial side of the first molar premolar to the distal side of the first premolar to the mesial distal side of the first molar. This is how the arc-shaped defect looks like in the clinically, and it is said to be bilaterally symmetrical. Then we will see about generalized aggressive periodontitis. As the term involves, the generalized aggressive periodontitis is there will be generalized interproximal attachment loss affecting at least 3 permanent teeth other than first molar and incisor, and the individual under the age of 30 will be affected, but old patient may also be affected. There will be a poor antibody response to the pathogen present. The destruction appears to be occur episodically. That means within the period of advanced destruction followed by the stage of quiescence of variable length, and there will be increased amount of P. gingivalis, A. comitans and Tenella forsythia frequently detected in the plaque of this generalized aggressive periodontitis patient. This is how the destruction will occur. First, there will be a period of exacerbation and there will be a period of quiescence. In case of period of exacerbation, we can see there will be bleeding may be occur spontaneous with slight stimulation, or suppression may be an important feature. In case of period of quiescence, there will be a gingival tissue may appear pink, free of inflammation, occasionally with some degree of stippling may also be absent, but there will be deep pocket can be demonstrated by probing. This is the clinical demonstrations for the generalized aggressive periodontitis patients. And some patient may have a weight loss, mental depression and general malaise. The patient should receive medical evaluation to rule out the possible systemic involvement. As we seen with LAP, that is localized aggressive periodontitis, cases of GAP may be arrested spontaneously or after therapy, whereas other may continue to progress inexorably to tooth loss despite intervention with conventional treatment. Now let us see about radiography finding of generalized aggressive periodontitis. The radiography picture of GAP can range from severe bone loss associated with a minimal loss number of teeth to advanced bone loss affecting the majority of teeth in the dentition. A comparison of radiograph taken at different times illustrates the aggressive nature of the disease. Whereas in localized aggressive periodontitis, as we already mentioned, in our localized aggressive periodontitis, we can see arc-shaped defect, whereas in generalized aggressive periodontitis, there will be severe bone loss of the patient. This is the difference between localized aggressive periodontitis and generalized aggressive periodontitis. In case of age of onset, there will be a circumpubertal onset in localized aggressive periodontitis. In case of generalized aggressive periodontitis, mostly under 30 years of age. Microorganisms, most predominant microorganisms said to be aggregative bacteria, actinomycetum comitans. And in case of generalized aggressive periodontitis, the predominant is said to be Porphyromonas gingivalis and aggregative bacteria, actinomycetum comitans. The local factor, there will be minimal amount of local factor at the site of destruction. In case of generalized aggressive periodontitis, there will be abundant amount of plaque and calculus. In fibrillar aggregation, there will be strong association. It is not very clear in generalized aggressive periodontitis. The pattern of destruction is mostly in localized first molar and incisor involvement with interproximal attachment loss on teeth, on at least one teeth or two permanent teeth. And in case of generalized aggressive periodontitis, there will be generalized interproximal attachment loss affecting at least 3 permanent teeth other than first molar incisor. The serum antibody response, we can see there will be rapid and severe loss of alveolar bone in localized aggressive periodontitis. In generalized aggressive periodontitis, it will be episodic in nature. That is, initially there will be a period of exasperation and there will be a period of quiescence followed by. In radiography finding, there will be vertical arc-shaped bone loss around first molar. In case of generalized aggressive periodontitis, there is a generalized extensive bone loss. Now let us see about risk factor for aggressive periodontitis. There are various risk factors that can contribute to aggressive periodontitis. First one, we will see about microbiological factor. Although several microorganisms frequently are detected in patients with LAP, that is localized aggressive periodontitis, which include aggregative bacteria, actinomycetum comitans, Capnocytophaga, E. cannula, Choroidans, Prevotella intermedia, and Campylobacter rectus. Aggregative bacteria, actinomycetum comitans has been implicated as a primary pathogen associated with localized aggressive periodontitis. This is the most important causative organism for aggressive periodontitis. In case of chronic periodontitis, there are many microorganisms which include red complex and other microorganisms, other complexes which causes chronic periodontitis. Then comes immunological factors. Some immune defect have been implicated in pathogenesis of aggressive periodontitis. The human leukocyte antigen, which will regulate immune responses, have been evaluated as a candidate marker for aggressive periodontitis. That is, in human leukocyte antigen, HLA-A9 and B15 antigen consistently associated with aggressive periodontitis, and hyperresponsive of monocyte from LAP patient involving the production of prostaglandin in response to the lipopolysaccharide. The possible mechanism, these are the 4 possible mechanisms which can increase the expression for the following. The first one is said to be major histocompatibility complex 2, and second HLA-DR4, there will be altered helper or suppressor T cell function, and there will be a polyclonal activation of B cells by microbial plaque. The genetic factor, obviously the localized aggressive pattern, localized aggressive periodontitis will occur in the familiar pattern, and all individuals are not susceptible to the aggressive periodontitis. There is a familiar pattern of alveolar bone loss have implicated genetic factor in aggressive periodontitis. Segregation and linkage analysis of families with a genetic predisposition of LAP suggests that is a major gene or set of genes plays a role in LAP and are transmitted through an autosomal dominant mode of inheritance. And Van Dyke et al. Reported that the familial clustering of neutrophil abnormality is seen in case of localized aggressive periodontitis. This clustering suggests that the defect may be inherited. The antibody response to the periodontal pathogen, particularly A. comitans, is under genetic control, that is ability to mount high titers of specific protective antibodies, primarily IgG2 against A. comitans, may be race dependent. Then comes environmental factor. The amount and duration of smoking are important variables that can influence the extent of destruction seen in young adult. Patients with generalized aggressive periodontitis who smokes have more defected teeth and more loss of clinical attachment than non-smoking patient with generalized aggressive periodontitis. However, smoking may not have the same impact on attachment level in younger patients with localized aggressive periodontitis. Then we will see about prognosis. Prognosis is nothing but we are going to predict the outcome. First one, the prognosis depends mainly about the severity or second depends upon the localized, whether it is localized or generalized, and third about the ability to control the future progression. In generally, the local aggressive periodontitis has a fair prognosis. If it is severe, it leads to the poor prognosis. In the age of puberty, if it is diagnosed earlier, there will be excellent prognosis and treated with systemic antibiotic therapy and oral agent instruction. And young patient with GAP does not respond well to conventional periodontal therapy. Therefore, patients often have poor and poor prognosis. Then we'll see about conventional therapeutic modalities or treatment modalities. The conventional periodontal therapy, the earlier the disease diagnosis, the more the conservative the therapy, the more the predictable the outcome. The conventional periodontal therapy for aggressive periodontitis consists of patient education, oral agent improvement, scaling and root planning, and regular recall maintenance. And it may not include the flap surgery. Now let us see about the treatment modalities. There are two therapy for periodontal. Initially, it is said to be non-surgical and then surgical therapy followed by. Initial therapy, non-surgical therapy, first we will move on to the anti-infective therapy. The most anti-infective drug is said to be doxycycline for aggressive periodontitis. Because the doxycycline inhibit collagenase and other matrix metalloproteins so that there will be less destruction of periodontal structure, so that the prescribed dose for doxycycline is around 200 milligram for aggressive periodontitis patient. Then followed by scaling and root planning, then local drug delivery. There are many conventionally available local drug delivery like tetracycline, chlorhexidine, doxycycline are available. Then come host modulation therapy, then full mouth disinfection. Once the non-surgical therapy is done, if the patient does not show any response, then we'll move on to the surgical therapy. In surgical therapy, we have two therapies. First one is resective and regenerative. Depends upon the walls available, we'll move on to the resective or regenerative. In regenerative, we can place a bone graft or membrane to regenerate the constructive structure. In resective surgery, we are going to reshape the surrounding structures around the teeth. And after the non-surgical and surgical, obviously, we want to go for the periodical maintenance of the patients. Then I conclude that knowledge and understanding of the clinical feature of the disease will help in diagnosis and treatment modalities. Optimal plaque control is a paramount importance in this patient for a favorable clinical outcome. And these are my references, and thank you students for watching.